Module 3, Reproduction. We're talking about the concepts of reproduction. We'll also be entering in discussion about perfusion, oxygenation, pain management, patient-centered care. Labor and delivery, that's all about the process. The readings were to be chapter 12, 13, and 14. Labor is a process and it's multidimensional. There's a physical piece and there's an emotional piece or a psychological piece, and they both work together. We tend to focus more on the physical side of labor than we do on the emotional or the psychological side because we can measure that and we can manage that, but you have to put them both together. Women are multidimensional. They have a psychological, an emotional, a biophysical portion of them, and they bring it all with them when they enter your labor rooms. So you must respond to their needs. You need to be asking them lots of questions, learn a little bit about them so you know how to help them cope with this process of labor. Your role, you're responsible both to the mother and the baby. Mother can be seen, baby cannot. So we have to be able to measure the response of the baby through this laboring process. Let's talk about the 5 Ps. That's how your textbook starts the conversation. The first P is powers. The power to push the baby through. Powers represent the contractions, first of all. Please understand that the definition of labor is uterine contractions, regular uterine contractions, that cause cervical change. Without the cervical change, all you have are uterine contractions. Let me also state right now, and I think I've stated it before, the uterus is a muscle, a large muscle, and it requires food, fluid, and rest. If you do not provide it one of the 3 or all 3 of those components, it will not be efficient or effective in this process. Labor is the process of moving the baby from inside the uterus to outside the uterus. The uterine muscle fibers are designed specifically to push that baby down and out. A way to think about it or conceptualize it is as a turtleneck sweater being pulled up over the baby's head, if that helps you. So the uterus gets shorter with each contraction. Now this doesn't happen quickly. Labor is a process that can be 24 hours long, some longer according to some stories. So you have to understand that it's a very slow process that we have to be patient about. And we will talk about the different stages and phases in a minute, which will help you understand some of what's going on. So the first power is the contractions. Our goal for contractions are every 2 to 3 minutes. Please understand that we don't want them any closer together than that for 2 reasons. It affects the uterine muscle, and if the uterine muscle is contracting too frequently, it will get fatigued, and if it gets fatigued, it can't do the work it needs to do to expel this baby. The second portion is every time you have a contraction, you're causing a bit of hypoxia. That's a bit of a strong word, but it helps you conceptualize. A little bit of a hypoxia to the baby. The uterine contractions decrease the perfusion of blood flow to the placenta, hence the less oxygen to baby. So if the contractions were too close together, the baby wouldn't cope. He'd have no oxygen reserve. Because he's going to go through lots of contractions, initially the contractions are far apart, very gentle, and so the perfusion issue is not a big problem. But as she moves into active phase, transition phase, and actually pushing the baby down, those contractions are closer together. They are stronger. Hence, there's less oxygen being supplied to the baby. So what's happening to him? The baby has a larger or a higher concentration of oxygen in his blood than we do, which allows him then to have the reserve to work through this. But if the contractions were very close together, he would use up that reserve very rapidly. So as the contraction is occurring, the oxygen and nutrition to the baby is decreasing, but then when the contraction is over, all that oxygen should be resurging through the placenta, hence through the baby. That is one part of the power, is the contractions. The other part of the power is the expulsion of the baby. That happens in 2 ways. A natural mechanism, which is called Ferguson's reflex, Dr. Ferguson, I'm sure, which the mom has this uncontrollable urge to bear down and push the baby out. It's Ferguson's reflex. The other power is Valsalva, which we help her with. We help her push the baby down. We have her hold her breath and bear down, hold her legs back, the Valsalva. If she has the Ferguson's reflex, we don't have to help her with the Valsalva because she's going to take over the expulsion on her own. But with the advent of epidural anesthesia and the loss of feeling, we now have to help her and educate her on how to push her baby down and out. So the powers are the contractions and the expulsion effort. Passageway. Passageway is divided between the bony pelvis and the vagina and the cervix and the introitus. So the bony pelvis, the narrowest part of the bony pelvis is the ischial spines. So the baby's got to be able to get through those ischial spines. And we measure that by doing a vaginal exam, which we'll talk about as we move through this. The vagina itself, of course, will stretch and give to encompass any size baby that's there. It stretches and gives a lot better if the vagina is healthy. So eating well, not smoking, not using a lot of drugs, or decreasing the perfusion to that tissue is going to help the vagina stay healthy, so it will stretch and allow this to happen. The introitus also, the musculature of the pelvic sling, that musculature has to also give and stretch. And if you're a super athlete to run all the time, that muscle may not stretch as easy as you'd like it to because it is built up, it's strong. On the other hand, if you've had poor perfusion to that muscle, it may tear easily, or there might be some scar tissue there from a prior birth, which means it won't give easily either, and we may have to cut. So allowing the introitus to get larger would be through the use of an episiotomy, and we'll talk about that later on as we move through the process here of birth. The position of the mother and the baby is crucial. If we think about the process, we know that gravity would be our best friend trying to get the baby down and out. However, we lock women into bed with the fetal monitors and tell them, please don't move, don't change your position because I won't be able to hear the baby. So lay here, lay on your left side preferably, but lay here and don't move much and don't move the monitor because I'll lose contact with the baby and I'll lose that monitoring. It's really unfortunate what we do. And then we put them in a lithotomy position, Lithotomy, I believe is how we spell it, lithotomy, which is the mother actually on her back with her legs up in the air, pushing the baby down and out. So we're kind of working against gravity, but that position is used for the provider or the nurse midwife so that they can see the perineum and assist in the birth. So again, in most hospitals, that's the position of choice. You get out of the hospital into a birth center or a home birth, you will find that gravity is used frequently to assist in the birth of the baby. Position of the baby. It's imperative that we know the position of the baby. And if you look into your textbook on page, let me find it one second, I want to say page 362, we have fetal position, which is the vertical or longitudinal lie of the baby, the fetal lie. And you need to identify that by doing your Leopold's maneuvers, correct? You would know the position of the baby by doing Leopold's. Now, if the baby's in a transverse position, or what we call an unstable lie, there are risks to that, and of course the baby cannot deliver vaginally in that position. So we'd want the baby to be in a vertical lie, either vertex or breech, vertex being the word for head down. Fetal attitude. If he is head down, is his chin flexed into his chest or is his chin up? And if his chin is up, that means the widest part of the baby's head is trying to come through first, which makes birth a little more difficult. It's doable, but difficult. And then fetal presentation is what is entering the pelvis first. Is it the head? Is it an arm? Is it the face? Is it brow? Is it butt? Is it legs? Is it foot? So you need to identify that by doing a vaginal exam. Now, in the past, we allowed breech presentations to deliver vaginally, but now we don't do that. So it's crucial that you really know the position, the lie, and the attitude of the baby so that you can proceed with labor knowing that it is going to be safe and possible. Okay? The other thing that you see on page 365 are the different positions that the baby might lie in, and this is a 3-letter denomination to describe the position. Don't get too hung up on this. It's good to read it and conceptualize it, but you don't have to memorize this. You'll hear the words, though, sometimes in labor and delivery when they say the baby is ROA, ROA, meaning that the baby's back is on the right side of the mother, facing forward. If he's LOA, that means the baby's back is on the left side of the mom, in a vertex position, facing forward. The baby's actually facing towards the back, but the baby's back is towards the mom's abdomen. And you can see that in these different pictures. So you'll hear those different lettered announcements at times when the nurses are describing where the baby's at and what position he's at. And then the psychological aspect of the labor. If mom doesn't feel safe, if she's afraid, if she's having conflict with whoever is her support person, she will not labor efficiently. She needs to feel safe in order to labor efficiently and comfortably. And so it's really our role, because she's entering into a foreign or an unfamiliar environment, to make her as comfortable as possible, as quickly as possible, so that she feels that she's doing this work that she has no control of in a very safe environment. I've seen women stop their labor. I've seen labor impeded because of fear. We also know that fear accelerates the perception of pain, so we also want to alleviate that also. I'd be asking questions to my patient. Did you do childbirth classes? Did you have prenatal care? Knowledge sometimes alleviates that fear, and so we want to help her with that. Answer her questions. Give her a little bit of insight into what is going to happen while she's in your labor suite. So the 5 Ps. And I would strongly encourage you to read through that, but don't get hung up too much on that. We will talk about the vaginal exam later. I've noted that that is described on your page 363 and 4 and 5, but we're going to talk about that in depth when we get to the labor portion. Some of the signs and symptoms of labor, again, the definition is regular uterine contractions with cervical change. Prior to going into labor, some women will describe a feeling like the baby's really dropped. It's really down there now. It feels like it's between my knees. I have so much pressure in my pelvic area now. I can't get comfortable. I can't sleep. I walk. I feel like I have to hold the baby up. That's called lightening. Prima gravidis may feel it more than multiparous patients, but it's a phenomenon that does happen, puts the baby into position, kind of puts him in a descending position, so we know that things are getting closer. Bloody show. As the cervix starts to open, remember there's a mucus plug that kind of plugged up that cervix to hopefully decrease the amount of ascending infection or bacteria from the vagina. That little mucus plug will start to be lost, or start to, there's somewhat of a bloody discharge or a mucousy discharge when that cervix starts to open a little and thin out, because we lose that plug. And as the cervix is opening, remember it's very vascular, so as it's opening, some of the blood vessels will break, causing a little bit of spotting or bleeding. Now if she has frank red bleeding, or more bleeding than just a little bit of spotting, she needs to alert somebody to that, because that might be a sign of something much more ominous than just a little bloody show. If there's any question, she should always come in and be examined so that we can ensure that baby and mommy are doing okay. I would much rather have a patient come in multiple times with questions and concerns than stay home second-guessing and find out that we could have made a difference. Contractions, again, the work of the contractions, or the work of the power of the uterus, has to be a timely thing. It's not something that just is very irregular. Irregular contractions are not efficient, and they will not make for the labor process. Normal, healthy, real contractions start out about 20 minutes apart, and slowly over time get closer and closer until they're anywhere from 3 to 5 minutes apart. Remember, we said our goal is 2 to 3 minutes apart for efficient, effective uterine contractions. When they're very far apart, they're not very effective, and the uterus isn't really pushing that baby down. If they're too close together, again, you have muscle fatigue, it's inefficient, and we can have some problems for the baby as well. So real, true labor, the contractions are far apart and get closer. Now, what can cause a woman to feel like she's in labor, knowing it's not. Number one, remember we said the uterus needs food, fluid, and rest. So if she's dehydrated, she's been asleep all night, so she's going to wake up dehydrated. She's going to wake up with a full bladder. Both of those things will cause uterine contractions that make no cervical change. Intercourse with the semen. Semen itself is prostin. Prostin is used to soften the cervix. So if she had intercourse, that too can cause some uterine contractions, and those are usually right on top of each other, a minute apart or 2 minutes apart, which frightens women. They think they're actually in the end stage of labor, when indeed it's just that it's very irregular. So again, false labor, we change our position, we drink some water, may make the contractions go away. Real labor, we drink some water, we get up and move around, makes the contractions closer and stronger. So that would be the difference. Energy burst. A lot of women have this nesting, and they go through this pulse of energy where they want to clean everything, and they want to fold the baby's clothes, and then they refold the baby's clothes, and then they refold the baby's clothes. So it's an energy right before the baby's born. Hence, we sometimes see some weight loss a week or so before labor actually begins. And that's what was the next point, was weight loss. Nausea, vomiting, and diarrhea. Again, I think this is a cleansing mechanism. When she's going into labor, all of our other systems start to slow down or shut down. Peristalsis slows down, GI peristalsis slows down, so people tend not to be very hungry, or if they are hungry, they just want a couple bites. They might get really nauseous. They may even have some vomiting while they're home. Diarrhea is another sign because it's kind of a cleansing system. If the bowel is irritated, and some women have used enemas in the past to cause labor to start, because when the bowel is hyperperistaltic, it can cause some uterine activity. If you do enough uterine activity, you will cause labor to begin. So those might be a sign that labor is impending. General malaise. Women just come in and complain, I just don't feel well. I can't explain it. My back hurts a little bit. I just feel nauseous. I feel like I got the flu. And I don't want to have the flu. The babies do. Well, she's probably in those early phases of labor. When should she come to the hospital? The general rule of thumb has been, for my patients, when I talked with them, was a prima gravida every about 3 minutes apart. Have the contractions to be about 3 minutes apart for a full hour, because it takes a little longer for the prima gravida to thin her cervix than someone who's had a baby before, the multiparous patient. So prima gravida, I tell every 2 to 3, let your contractions be 3 minutes apart for a good hour before you come in. The multiparous patient, 5 minutes apart, because she's going to move through labor a little quicker. The rule of thumb is a prime from the very first contraction to the delivery of the baby is approximately 24 hours. Now that's not everybody. There's exceptions to every rule. But that's kind of the guide that we use. Plan about 24 hours. So that first phase of labor takes a long time before they get into an active, repetitive labor pattern. But the multiparous patient is about half that or less. So we have to help them. We have to guide them. Also, if she can talk through her contractions, she's not in a labor pattern that we need to be too concerned about at that point. And again, if you worked in the labor suite, you would recognize some of those things. All right, labor normally moves through 4 stages, and within those stages are phases, and this is kind of important for you to embrace. The first stage is called labor. Right, labor takes you from the way we physiologically identify it is that the cervix is closed up to about 3 or 4 centimeters dilated. Now, please understand that the cervix has to change over time. The cervix, remember we said, is about 3 to 4 centimeters dilated, and it's going to start to thin out. That's its first. As that turtleneck sweater is being pulled through, it's going to thin before it will open. So we're going to see effacement, or the thinning of the cervix first. Then we will see the cervix start to open, and that's called dilation. So those are 2 pieces of information that we will gather each and every time we do a vaginal exam. We'll ask dilation and effacement. The third piece of information that we will ask for is station, and that is where the baby's head, or presenting part, is in correlation to that ischial spine, the narrowest part of the bony pelvis. And when you look at the pictures in your textbook, which are on page 364, that gives you a very clear understanding of station. The baby's head is lined up to that ischial spine. Now above the ischial spine is a minus station, and below the ischial spine is a plus. And we have a little ditty that we say in labor, +4 on the floor. So that gives you the idea that if it's plus, it's moving down. If it's minus, it hasn't gotten down there yet. So if I say to you a patient is 3 centimeters dilated, 90% effaced, and -2, you would recognize that it is 3 centimeters open. In fact, I could put my finger, almost 2 fingers, inside a circle. That would be 3 centimeters dilated. That's not enough room for a head to come through. 90% effaced means it is very, very thin. It's almost to the point of being paper thin. And -2 station means that the head is above the ischial spine, so it's not putting a lot of pressure on that cervix yet. Okay? So I would say that she's in the latent phase, or the first part of the first stage of labor. So the first stage is the labor. It is the work portion of the process of getting this baby out. This is the longest stage. This is the longest stage of labor, because this is from going no dilation to completely 10 centimeters dilated, and that takes time. The second stage is the delivery of baby, and that goes from being completely dilated, 10 centimeters, to having the baby out. The third stage is the delivery of the placenta, and that's exactly what it is, and it takes anywhere from 5 minutes to 30 minutes to get the placenta to expel from the body. And your fourth stage we've added as a recovery stage, because it's very crucial and important that we are vigilant in monitoring our patients during the recovery stage of labor. You won't hear many of the nurses talk about the recovery stage. They do talk about recovery, but they don't talk about it as a stage of labor. But it is very important, because things are starting to revert back, and they do so rather quickly, and we will talk about that. But I wanted to outline to you that there are 4 stages of the laboring process. So let's look at the first stage. The first stage is labor, and in that stage there are 3 phases, and the very first phase is called latent, meaning less than, small, not very effective, not efficient. So what's her support system like right now? First of all, let's identify that when the patient walks in. Is she going to have someone with her? No woman should labor alone, in my opinion. And if she doesn't have a family member or a friend that's going to be with her, we need to take on that role, because it's very frightening. She doesn't understand the equipment. She's in an unfamiliar environment. She feels locked down because you've got her in a bed. You put an IV in her arm. You've told her to stay put and don't move. She's scared to death. She doesn't know if she can even look around the room, let alone get up and go to the bathroom. So we need to be her best friend, okay, and really support her and give her all her, help meet all her needs. What will she tell you when she comes in the latent phase? I'm cramping, I might have some bloody show, low backache, I'm still talking through the contractions. If I were actually to time the contractions, they're probably about 15 minutes apart, 10 minutes apart, maybe 5 minutes apart. They're getting a little stronger now. I'm getting uncomfortable. Baby's moving in between the contractions, but I can talk to you. In fact, I'm pretty excited that this is finally it. No, my water hasn't broken, or maybe my water has broken. But I'm kind of excited, and if this is as bad as labor is going to get, what's the big deal? So you see, they're excited, they'll be chatty, they want to convince you that this is the real thing because they don't want to be sent home again. They'll do whatever they have to do to get you convinced that this is labor. I want to ask her when's the last time she ate or drank anything, because that will give me her hydration status. She might be contracting every 2 minutes, but is it because she's dehydrated, or is it because she's in labor? Is it because she had a full bladder and had sex a little while ago, or is she in real labor? So we need to find out what her hydration status is. What should I do? I'm going to put her on a fetal monitor. That's probably the first thing I'm going to do, because I can see her, but I can't see the baby, and I want to know how well this baby's coping with the laboring process. So I'm going to put her on a fetal monitor. Then I'm going to talk to her after I've put her in a gown. I'm going to put her in a semi-Fowler's position or left lateral position, whichever is a little more comfortable. Probably semi-Fowler's is really the best. And I'm going to start asking her lots of questions about her prenatal history. When did she start it? What was her blood pressure like? Were there any problems? Is she safe? Who's her support system? Does she know her blood type? What about her GBS status? GBS status every woman knows, and you can ask every woman that has had prenatal care what her GBS status is. If she is positive for GBS, of course, I'm going to start antibiotics. Group beta strep. That's what GBS stands for, group beta strep. What else should I do after I've got her on the monitor? I've got her relatively comfortable. If she says she has not had any trickle of fluid from her vagina, then I'm going to assume that her bag of water is still intact. And I'm going to do a sterile vaginal exam. Just a digital exam with my fingers, and I'm going to assess 5 pieces of information. I'm going to assess dilation. I'm going to assess effacement. I'm going to assess station. I want to be able to know what the presentation is. Is this baby vertex, breech, transverse? What is presenting? And the last thing that sometimes you can tell is if the bag of water is intact or not, because if it's slippery beneath your fingers, the bag of water is intact. If you feel something coarse like hair or baby parts, then it may be broken. We've talked about what we should ask. So how do I proceed now? Try and get her comfortable. If she's in the latent phase of labor, I'll probably start an IV. Give her lactated ringers. That's usually the IV of choice for labor, lactated ringers. I'm going to probably give her also a 500 milliliter bolus because she's probably somewhat dehydrated. If she's been contracting a while to make her cervix start to change, then she probably hasn't had a lot to eat or drink. So let's give her a 500 milliliter bolus. It's not going to hurt anything. The key that I must be vigilant about is her bladder, making sure that her bladder stays empty. So I would offer her to the restroom every couple hours, or get her on a bedpan every couple hours, or if indeed we need to catheter, that's what we will do. Start your documentation, start your watching of what's going on, watch her behavior, look for any increase in bloody discharge, watch for any change where she's got a gush of fluid, and I would start watching the fetal heart rate. Now if I find that she's not really making cervical change, that she really doesn't act like she's in labor, her contractions are kind of spaced out, but she's close to her due date, then I might send her walking for an hour. But when she comes back, I have to put her back on the fetal monitor to assess the fetal well-being before I can make a decision if she goes home or stays. We always do at least a 30-minute fetal monitor strip to assess the baby's well-being under 30 minutes of environmental changes. Because hopefully in that 30-minute time frame she's had a few contractions so we can assess how well the baby copes with that hypoxic event. What will we see on the fetal monitor? Hopefully you've listened to the fetal monitor presentation before you're listening to this one, because you know we look for 5 pieces of information there as well. We look for baseline, variability, accelerations, decelerations, and then maternal activity. Usually, and the baseline should be between 110 and 160. You have to choose one number. You can't say a range, you have to choose a number. It's the number that you see most frequently on the fetal monitor. Baseline. Then we have to assess variability. Is it marked, moderate, minimal, or absent? Of course, marked is the best. That means the baby has the best oxygen supply, loving his environment, very reactive to environmental changes. This is a healthy baby. A mom who's dehydrated is going to have a baby with minimal variability. A mom who had a cigarette before she came in is going to have minimal variability. A mom who has hypertension or is using drugs or was given some drugs before she came into labor is going to have minimal variability. Now that will frighten you when you first see it, because like, why does this baby look unhealthy? Why does the baby not have any response to his environment? So I need to backtrack. I need to do some clinical puzzle piecing together. I need to ask questions. I need to start the fluids and see if that makes a difference. I need to change her position to increase the perfusion to the uterus. We always change mom's position to the left side to increase placental perfusion if possible. So I'm looking at variability. Then I look for accelerations. Accelerations, as we said in the fetal monitoring presentation, are always positive. They're always healthy. It's always a good thing. So if we see accelerations, we know this baby's coping quite well and can handle whatever comes his way. If we start seeing decelerations, we need to assess what type of decelerations, where in the laboring process is this happening, and then make a plan. And the very last thing I want to assess is maternal activity. Is she contracting? Do I have the belts on correctly to pick that up? Because if you have the belts too loose, you will not pick up contractions. If she's extremely obese, you may not be able to pick up those contractions. All right, so how is the baby coping with labor? Again, some objective assessments that we will do is to put the fetal monitor on her, and we can palpate contractions to assess whether they're strong or mild. You cannot tell strength of contractions by the external fetal monitor. You can only tell frequency. We want to listen to the baby's heart tones, as we said, because we want to know how the baby responds to the contractions. And then, of course, do the vaginal exam, which will give you dilation, effacement, station, presentation, and the status of the membranes. But the three things that you're going to most focus on are dilation, effacement, and station. Some of your interventions, of course, we're moving now into the active phase. That was the latent phase. Latent phase is the longest phase and the most variable phase. There is no time stamp to latent phase. She can be in the latent phase for a couple days. That's not unusual, and unfortunately we could correct that by making sure she's eating, drinking, and sleeping to make those contractions either stop or make them more efficient to put her into labor. But latent phase, as long as she's not changing her cervix, there's nothing for us to do. We leave her alone pretty much, unless we're needing to get the baby out, and then we would augment the labor. But in the latent phase of labor, if everything is good, she's healthy, she's just at her due date or a little before her due date, we're not going to do a lot to accelerate labor or impede labor. Now let's move into the active phase, the next phase of labor. And the picture you see up there in the right-hand corner is about a 5-centimeter dilated cervix with about an 80 or 70% effaced cervix. And you see that shiny bulging bag of fluid. It is translucent. Unfortunately, we can't see the baby behind it, but you can see it's like a translucent, shiny balloon, and that's exactly what a bag of water kind of looks like. So that gives you an inside, in the vagina look at what a dilated cervix with a bag of water looks like. With the active phase of labor, we can put a time stamp on this process now. As she's becoming in the active phase, meaning she's opened her cervix down to about 4 centimeters, that means her contractions are closer and they're stronger, which means there's more of a risk to the baby. So the baby has stronger contractions, less perfusion, more oxygen deprivation, we'll say, to the baby during this phase. So we don't want labor to go on forever in this phase. Again, we'd have uterine fatigue, and we may have some risk to the baby. So we would expect that even for a prima gravida, we would expect to see that every hour to hour and a half, she's going to make a cervical change from 4 to 5, 5 to 6, 6 to 7, 7 to 8. So in approximately 4 to 6 hours, we should see her move through the active phase of labor. If she's not moving adequately through the active phase of labor, we would want to augment her labor or make it more efficient. And there are things we can do about that, and we'll talk about that in a moment. So again, she's going to be much more introspective now. Lots more uncomfortableness. She's going to tell you her pain is way above 10 centimeters, 10. She's going to be panicky. She's going to be breathing hard, or she's going to be holding her breath. She's going to be kind of nasty. I said it, very introspective. Please ensure that her bladder is empty at this phase because it will impede the descent of the baby's head if that bladder is not emptied. This is the best time to do pain management. And if you've done your studies for your different medications in labor, you would know that there are some opioid-like drugs that we can use. Stadol and Nubain are the drugs of choice. Demerol is also appropriate but not favored because of the increased risk of respiratory depression to the baby. It has a longer half-life and it hangs around longer in the baby's system. So yes, they may breathe initially, but he may not continue to breathe efficiently after he's born. So we tend to shy away from Demerol if we can and use the Nubain and the Stadol. We would give it IV push, and we give it at the peak of the contraction, so less bulk of the medicine is going to the baby initially, right? So that is our plan if we're going to do systemic medications. If she wants an epidural, that's another discussion, and we're going to come and we're going to talk about pain management as we go through. So please understand the things you need to recognize in the active phase. This is a stronger contraction, closer together. Mom is more introspective. She's not excited anymore. She doesn't like this anymore. She's not happy anymore. She wishes she could get up and walk around, and of course now is when we kind of keep her locked in the bed because we want to see what the baby's doing. It's unfortunate, but that's what we do. Now if she's in a home birth or a water birth, that does not happen. We're watching the baby on the monitor, and we're going to talk about that change in just a minute. So pain management is a really good thing. Now Demerol, Nubain, Stadol really don't take a lot of the pain away, but they do allow her to cope and relax. Remember, labor, I should have said this in the beginning, the key to labor is relaxation. If she is tense, we have to help her with that. We got to get the death grip off the bed. We got to drop her shoulders, help her take the frown off her face, have her stop scrunching up her toes, relax her pelvis, open her legs. Babies won't be delivered with legs that are closed, so we have to let her sit with her legs kind of open to allow room for that baby to start descending. What is she going to tell you that she hurts? That she's scared, she can't do this, I can't do this, I can't do this, I want to go home, I want to stop whatever we're doing, I'm done, this is over, you better fix it, give me a C-section, do something, get it done, get it out. They're panicky, they're nasty, they slap, they squeeze, they pinch. I've had people bite, I've had people pull my hair, pull my clothing, whatever, because they're out of control a little bit. What should you do? Get her back into control, get her to focus on you. Get her to breathe. Please don't let her hold her breath, and don't let her hyperventilate. She hyperventilates, we give her a paper bag, but hyperventilation is a real problem in labor because they tend to hold their breath or breathe inhale, but they forget to exhale. So staying with her, getting her comfortable, providing her some pain management, staying with her until she's comfortable, talking to the family so they understand what's happening, and can provide the support too, because daddy and family get a little scared too, because this is not a behavior they've seen out of this person before. What should you ask? Is your water broken? Do you feel like you have to pee? Let's change your position. What do you want for pain? And at this point they'll probably agree to just about anything, so you have to be careful. This is where we say we have very vulnerable patients. How do you proceed? Before you give any pain medication, you really need to know what her cervical status is, because you would not want to give pain medication right before she delivers the baby, because then the bulk of the medication is going to the baby rapidly, and we want to wait until some of it is worn off the baby to deliver. So let's check her cervix before we give her any pain medication. In the active phase of labor, she'll be anywhere from 4 to 8 centimeters dilated. Hopefully she's completely effaced, and hopefully the head has come down now to the 0 station, or maybe -1 or 0 station, but there's been a descent a little bit of the head, and that's good. So change your position. What will I see on the fetal monitor? I might start to see a decrease in variability. The baby's getting a little tired. The contractions will be closer together, and I might even start seeing some decelerations, some early decelerations, which are suggestive of head compression. Now what we do not want to see are late decelerations, because that's suggestive of placental perfusion issues. And you might see some variable decelerations, because that's cord compression. The cord might be entangled somewhere that every time she has a contraction, we're seeing a deceleration. So you'll need to be able to recognize what you're seeing on the fetal monitor before you start giving a lot of pain medication. If you see a decrease in variability, you know that when we give the medication, that's going to get worse. So you want to be very careful that the baby has good oxygen supply and is responding positively to his environment before we give him a drug that is going to decrease those things. Okay? So that's the active phase of labor. There is a time stamp, and we would expect that she will meet the parameters of that labor curve. In your textbook, I believe it does talk about the labor curve, and I'm not sure on what page it talks about those things. In fact, maybe it doesn't talk about it. All right. It used to be called Friedman's curve, but Dr. Friedman, apparently his name's been taken off of it, as in the Heimlich maneuver, Dr. Heimlich's name's been taken off of it. But they need to make the positive changes. Now let's move into the some nursing interventions. Again, this takes you through. The patient will be more introspective. We're going to see changes of the vaginal exam. That's what the VE stands for. Vital signs. The blood pressure might rise a little bit because she's uncomfortable or scared, so we want to be helping her with that, making sure we're keeping her relaxed, changing her position. Doesn't mean she's preeclamptic or having any hypertensive crisis. Keep her focused, relaxed, watch for hyperventilation, which we talked about. Good time to medicate, encourage the empty bladder. Why? May start to feel a little pushy, so what do we want to do? You do not want her to push through a cervix that's not completely dilated because it will tear. And remember, the cervix is extremely vascular, so if it starts to tear, it's going to bleed heavily. She might get a little nauseous, so we can give her medication for that, have her have some ice chips just to try to relax her tummy. Phase 3, transition. Fear and anxiety is going to be the worst, so you'll need to stay a little closer to your patient at this point. Transition moves pretty quickly. It is exactly what it is, the transition from labor to the transition to start pushing. And it moves quick, so at 8 centimeters to 10 centimeters goes rapidly, anywhere from 30 minutes to 2 hours. Usually the time stamp is 2 hours maximum before she can start pushing. But we try to keep her from pushing down if we can. So helping her relax, changing her breathing pattern, giving her a little more pain medication if we need to, changing her position so she's not sitting up so much so that gravity is now working and we'd like it to not work, so we want to lay her down a little bit so she's not working with gravity. What she's going to tell you is, I have to push, I have to push, I have to push, I can't stop it, please do something, fix this, and she's going to be screaming these things at you, and I'm trying to be very calm in my discussion here, but she's going to be screaming at you and pulling at you, and she's very, very frightened right now because her body's doing things that she has no control of. So what do? You stay with her. What is her vital signs going to do? Her blood pressure will be up, her pulse is going to be up, her breathing is going to be changing and altered. Things are moving very, very rapidly. The bladder needs to stay empty because as she starts to push down, the theory is, I've never seen it happen, but the theory is that we could rupture the bladder if she pushes against a full bladder. Probably, again, I have not seen it, I've not heard of it happening, but the theory is there, so let's get that bladder empty. The bladder also holds the head up so that the baby can't get down. And what do you ask her? What's her pain? If she's feeling like she has to push down, is it getting stronger? And how do I proceed? I want to start setting up the room, getting it ready for the birth, because once she goes into the stage of pushing, we cannot leave her. And what about the baby? Again, what's your baseline? What's your variability? You'll probably start seeing decelerations. Again, the early decelerations that means the head is moving down. So transition, scary, frightening. The second stage of labor is the delivery of the baby, and we're going to have her start pushing. And again, if she has an epidural, she's not going to have this urge too greatly, so we're going to assist her. We're going to pull her knees up. She's going to have her hold onto her legs, pull her legs back towards her chest, have someone push her to a sitting up position, almost in a pretzel position there, have her knees as wide as possible, and have her bear down into her perineum. Unfortunately, she wants to push into her face, or she wants to push into her chest, or push into her legs, or push into her belly. She doesn't really catch on to the concept of pushing in the perineum right away. So it takes a few pushes before she finally gets what it is you want her to do. So we really can't count those pushes against her. Please understand that the second stage of labor has a time stamp. From the time she's completely dilated to the time that the baby's delivered is 2 hours. Now, if she has an epidural, we can give her 3 hours, but that's it. And if she doesn't make a descent, if the baby does not descend appropriately, then we will be forced to do a C-section. Again, this is when the contractions are the strongest. So this is when the baby has the most risk of hypoxia. So this is why we have a time stamp on it and continually monitor the baby during this pushing phase, or this active second stage of labor. Eventually you'll see crowning, as that picture you see there, where just the occiput, or the back of the baby's head, is peeking through the labia. This is good because we know that the vagina is stretching. We know the baby's made it through the ischial spines. He's moving down. We're very excited. Now, that little string that you see attached to the head is the fetal scalp electrode. You probably won't see a lot of those, so I did like that picture so you could see it, and that is actually embedded into the baby's skin, and we kind of use a little spiral turn to screw those literally into the baby's head. Prepare for an episiotomy. So if you feel the baby is crowning, we need to have the provider in the room that's going to deliver the baby. You need to have everything ready, including the baby's warmer. That's probably where you need to focus the most, is make sure you have towels, blankets, hat, bulb syringe, and things ready for the birth of the baby. You want things warm because the baby's coming out of a 99.8 or 98.6, whatever mom's temperature's been, temperatured area, and you're going to move him into a 75-degree room. He's going to get cold very fast, and that is inexcusable to allow the baby to get cold. So the baby's crowning, you've been pushing with her, you've been helping her, you made sure her bladder's empty, you've got her in the proper position, baby sounds good, we're seeing some early decelerations of the baby's heart rate, so we know he's making progress, and we know he's coping quite well with this pushing phase. As the baby gets closer and closer to the perineum, again, the provider needs to be in the room. They may choose to do an episiotomy, and we're going to talk about what the episiotomies are and what they look like. Now, the baby's going to go through 7 cardinal movements through the laboring process, and you do not need to memorize this, but it's rather interesting that each baby goes through all through the same scenario. And when you look on page 386 and 387, you'll see the perineal bulging that happens as the descent of the baby there, and then there's a pictorial which is going to show you some episiotomies too. But the birth, when you look at page 387 and 388, talks about the cardinal movements of birth. Again, you don't have to memorize that, but recognize that each baby goes through each of those movements, and it's rather interesting. And if it is a multiparous patient that you're watching deliver, you'll actually see that baby's head spiral inside the vagina. You can't see that on a primate, but you will see it on a multip. I love this picture because it shows you where the focus is. The part of our body that we keep pretty private and to ourselves has now become on public display, which I find so amusing. And you see everybody smiling, everybody's excited about the fact that mommy is going to deliver a baby, but you see the position that mom is in, and that's the position you need to help her stay in for the pushing phase. She doesn't look so happy, but everybody else is very excited about the fact that the baby's almost here. Birth. Birth is the culmination of the second stage of labor, and again, we said there was a time stamp to that. You're going to be pushing and pushing and pushing, so you've got 2 hours. You cannot leave the patient. Don't take your eyes or hands off the perineum ever, because that's about the time the mommy's going to push that baby right out. So always either keep your hands or your eyes on the perineum during the pushing phase. Again, get your doctor in the room once the crowning begins. Then you become the timekeeper after that. You're no longer really a patient assistant. You're now kind of a timekeeper and a record keeper. You're keeping track of when things are happening. This video we will be playing in our study hall. I don't know if you'll be able to play it. I know I cannot play it here I don't know how to embed videos, so I will send these PowerPoints off as well. This is an episiotomy. Again, there's another PowerPoint attached that you can look at if you come to the study hall. But the picture up on the top left is a second-degree episiotomy. A second-degree laceration where an episiotomy had been started. And you see that the outside tissue, the vaginal tissue, has been torn, and then the vaginal mucosa, which is just beyond that, has also been torn. So this is a second degree. It's gone through the muscle layer of the vagina and has to be repaired. In all vaginal lacerations, we're going to provide ice to the patient. We're also going to provide analgesics. The second thing is if she has a second degree or greater, she'll start sitz baths. The picture to the right is of a third degree laceration, which means it's gone through the vaginal muscle and down to, but not through, the rectal sphincter. The picture on the bottom left is through the rectal sphincter, which now she has a fourth degree laceration. In picture 2 and 3, she needs to have stool softeners, and in the picture where she's got a fourth degree laceration, she's going to also need antibiotics to protect her from the E. coli that might come through the bowel there. These are very delicate repairs, and you want to protect that perineum once she's delivered. So pelvic rest would be crucial. The picture on the lower right is a cervical tear. Hopefully we don't see those very often because, again, very vascular, very difficult to repair, very difficult to see because that's pouring out blood. And remember, it's about 7 inches away from you, so you have to reach in, pull things down. It's very uncomfortable, very difficult. So we try to protect the patients from pushing through their cervixes, so an episiotomy. And that video will talk to you about the reasons for the episiotomy, how they're done. There are 2 types of episiotomies, as it shows on picture 387. There's a picture that talks about the midline episiotomy and the medial lateral episiotomy. Midline goes down towards the rectum, medial lateral goes towards the hip. The medial lateral takes longer to heal, but it protects the rectum. The midline is the popular episiotomy used, and then we just try to protect the perineum so it doesn't rip into and through the rectum. The third stage is the delivery of the placenta, and again there's a time stamp with this, about 5 minutes to 30 minutes. And the signs of placental separation are a gush of blood, lengthening of the cord, uterus becomes very globular, very hard to the point that it almost stands up in the abdomen, and the fourth sign is that the mother will tell you she feels a fullness in her vagina. So we don't worry about that gush of blood because that's expected initially after the birth. We expect a big gush of blood, and then she'll have the lengthening of the cord. What you don't want to do is manipulate that placenta too much. You pretty much want to leave it alone and let it spontaneously evacuate. Oftentimes it'll do that all on its own or just with mom bearing down a little bit. So she may have to push 1 more time or 2 more times. She may feel the contractions or she may not feel the contractions after the birth. Once the placenta is out, of course, we want to protect her from continuously bleeding, and so they often will start Pitocin. Your role and responsibility is to support the mom at this point, monitor the bleeding to ensure that she's not starting to have a postpartum hemorrhage, because that is the biggest risk right now, is postpartum hemorrhage. What medications do we give? We've just talked about the fact that Pitocin, which causes uterine contractions, will be given after the baby too. Now, we didn't mention it for labor, which I should have. If I need to augment the labor or make the labor stronger, I would be giving her Pitocin. We need to titrate Pitocin as long as the baby's in utero, because the contractions get stronger, closer, and the risk of hypoxia. So we titrate Pitocin very, very carefully. You do not run Pitocin without a fetal monitor and without it being on a pump, an IV pump. The ratio in most facilities is 1 milliunit of Pitocin to 3 milliliters of fluid. Once the baby's born, we no longer have to titrate the Pitocin because there's no longer a risk of hypoxia. We can give the mother as much Pitocin as we can crank into her to get her uterus to contract and stay contracted. Now it's very important that the uterus stays contracted, which causes a decrease in blood flow to the uterus, because that endometrial lining where the placenta was is like a big scar, and we need to close off those vessels and keep them closed so that they don't continue to bleed. So it's imperative that she stays contracted now. So Pitocin. If Pitocin does not work, we give Methergin. If Methergin does not work, we give Hemabate. One of the other drugs, and it is mentioned in your textbook under postpartum care, is Cytotec. Cytotec is also used for labor contractions and kind of softening up the cervix, but it can cause uterine contractions that will hold the contraction tight, or will hold the uterus tightly contracted. And we can give those postpartum. We give tablets. We take a 100 milligram tablet and we put it into the rectum. In fact, we go up to 800 milligrams to put into the rectum. Remember, there's a very small layer of tissue between the rectum and the vagina, so that is absorbed very rapidly into the bloodstream. After everything is over, the baby's out, the placenta's out, we repaired the episiotomy or the laceration. We want to clean her off from all the amniotic fluid and all the blood, put some dry clothing under her. Mommy's going to shake. That is very normal. She's expended a whole lot of energy in the last few minutes to get that baby out, and now there's a rapid drop in hormones. All the estrogen and progesterone are gone because it came from the placenta, so they're completely gone. So there's a whole hormonal shift. She might have a little bit of nausea, and now she might start having some contractive pains as that uterus and that blood and the cervix is trying to get back down to normal. So she might be having what we call after pains. If this is not her first baby, she's going to have a lot of after pains. If this is her first baby, she may not recognize them at all. The key is to keep that uterus contracted. You should feel it very firm under your hand at about the level of the umbilicus, okay? And that's where it needs to stay. Do we allow her to breastfeed? Absolutely. The act of breastfeeding causes an oxytocin release, which is natural Pitocin. Pitocin really is the synthetic side of oxytocin. So it's a natural release of oxytocin, which causes the uterus to contract, and it helps the ejection of the milk. So we want her to breastfeed as quickly as possible. It helps with the bonding, helps the uterus to contract. This is some pictures of placentas. You see the picture in the top left is where the baby would actually be inside the amniotic and chorionic sac. Picture in the top right is the way the cord should be actually embedded in the placenta, right into the center of the placenta. That is the fetal side, or what we call the shiny Schultz side. Lower left is an actual true knot in the cord. This baby does survive this. We see these, not a lot, but every once in a while you'll see a true knot in the cord, and it's always amazing to us that the babies could survive that, but they do quite well as long as it doesn't get too tight. And then the lower right picture is the maternal side of the placenta, and you can see all the little lobes or cotyledons that were where the chorionic villi connected for that gas exchange to the baby. You see that the size of the placenta is about 1/3 of the size of the baby. The fourth stage of labor, of course, is the recovery stage. And again, there's a time stamp to this stage. It's of 2 hours. This is when we should be providing comfort and support, helping her establish her new role as a mommy, helping daddy establish his role as a daddy, starting breastfeeding if they choose, but we're also assessing her for risk of hemorrhage. Pain assessment, if she's having a lot of discomfort, we're going to start with NSAIDs, but remember NSAIDs cause GI upset, so we want to give her some food if we're going to give her the NSAIDs. Our assessment needs to be completed every 15 minutes for the first hour, and then every 30 minutes for the second hour, and our assessment includes vital signs including temperature, a fundal assessment, and again the fundus is to be at the level of the umbilicus. Lochia assessment, how much bleeding is she having? A heavy period is what you're going to expect to see. And when you push on the fundus, you might see clots. You might see a little more trickling. That is normal. What you really want to do is make sure all the clots come out of the uterus, because the more they sit in there, the harder it will be for it to stay contracted. We want to assess her sensation. If she had an epidural, is she starting to get some of the feeling back in her feet and in her legs? What's her level of consciousness? If she's had a big bleed, we want to ensure that she's still alert and oriented with us. Now, she might be very, very tired and fall asleep, which is fine, but make sure that she arouses easily. Bladder, assess her bladder. Again, if she has lost sensation, even if she did not have an epidural, she might have lost some of the sensation because of the pressure and the trauma to the perineum during the birthing process. So ensure that she can empty her bladder. In fact, the way to get out of recovery is to empty your bladder and to ambulate to the bathroom if you had a vaginal delivery. Now, if the epidural hasn't completely worn off, they may move patients to the postpartum area without having completely worn off that epidural. But really, the rule of thumb is that anesthesia is supposed to be completely resolved before we move them. For a vaginal delivery, this does not include for a C-section, this is a vaginal delivery only. If she cannot empty her bladder, then you have to make the decision if you're going to put in a Foley or you're just going to cath her. But again, palpate where her bladder is. A distended bladder will elevate the uterus up into the liver. I call it hugging the liver. So when you cannot find the fundus at the umbilicus, you need to start looking for it. Start at the xiphoid process and start working your hands down her abdomen until you feel the firmness of that fundus. And you might find that it's 2 or 3 finger breadths above the umbilicus, and this is not appropriate. That means it will continue to bleed if the bladder is full. So please, please be sure the bladder stays empty. And then monitor her gait after. Does she have the ability to ambulate to the bathroom? Are her legs functional? Does she know? Pain assessment. Your pain assessment for labor, of course, begins when she comes into your labor suite. You want to find out what her pain assessment is like. Pain can be accelerated because of past history of birth experience and the trauma that she had. Some of the stories she's heard, and now she's very afraid. So fear will accelerate that pain. Culture may change the way she demonstrates her pain, either very vocally or very stoically. The time of the day may change her pain perception. People tend to have more pain or more fear of the pain at nighttime, and so we have more admissions to labor and delivery suites oftentimes at night because labor is she's having some contractions, and so she comes in. What's her stamina? Is she fatigued? People who are more tired are going to have a lower pain threshold or have more expectation or perception of pain than someone who's well rested. And what's her support system? Someone who's alone has more need for pain medicine than someone who has people with her. And we've studied that and we've proven that with literature. So we need to assess her pain in a multidimensional way, not just asking her what the number is, but look at a lot of other pieces. You really are not feeling the uterus. It's the cervix as it's opening that's causing the pain. We don't need to explain that to our patients, but she's going to describe it as pain coming through her back and starting at the top of her abdomen and working down. That is pain that is migrating. As you have other migrated pain, this is pain that migrates from the cervix. So it's the cervix that's opening, it's the tissue that's stretching that causes the pain, not the uterus itself. But we attribute it because it comes and goes, and uterine contractions come and go. We want to promote comfort during labor, and some of the ways we do that non-pharmacologically are changing her position, staying with her, offering her support, ensuring she has someone with her, getting her up to the bathroom, offering her ice chips or clear liquids. A lot of the hospitals now are opening to clear liquids. Rubbing her back, rubbing her feet, listening to music, doing some chanting. Hydrotherapy is wonderful. If you have jacuzzis at your hospital or if you have a shower and she can get into the shower for a little bit, that is a great way to help with the pain management. Pharmacologically, of course, there's the systemic medications, which I've already mentioned, Nubain and Stadol. Local anesthesia, where we inject the perineum or do a pudendal block, which are not done much anymore, but it is mentioned in your textbook, the pudendal block, which innervates the pudendal nerves, which gets very close to the perineal area, which then the cervical pain goes away. Most popular, of course, is your regional anesthesia, which is your epidural. Epidural anesthesia has become extremely popular, and I would say 90% of most women expect and do have epidural anesthesia. And we will talk about what we need to do for that unless, yes, okay, good. And then the very final type of anesthesia is general anesthesia, which can be used in the OR if indeed we have to put the mommy to sleep. But that's done very rarely because all general anesthesia goes directly to the baby as well. So there's a lot of risks, and we take a lot of caution when we decide on general anesthesia, and it's when all other forms of anesthesia have failed, or if we're in an extremely hurry and we've got to get the baby out quickly. So that is our pain management. Remember, you want to plan it in the first stage, second phase of labor, which is your active phase. We try not to give too much medication in latent phase because we'll relax the uterus a little too much and she'll stop contracting. And if we give it too late, then of course it all goes to the baby. So we have to time this very carefully. Hence, we would have to do a vaginal exam before giving any pain medication so we kind of know her status, where she's at in the laboring process, and how well the baby's doing. So if she opts for an epidural, what are some things that the nurse needs to do before an epidural begins? Well, number one, we have to have an order on the chart. This is anesthesia. It's very benign in our field. We give it a lot. I shouldn't say it's benign. We're become rather complacent because we give it so often, but there has to be an order. We then have to have a consent that she has agreed to this, and we certainly can't get the consent after she's had medication. Hence, we get all of our consents upon admission to the hospital. Whether she gets an epidural or not, we get the consent signed. Third, we have to have an IV. You have to have IV access to do any type of anesthesia, so make sure your IV is in place and that it is functional, that it's actually infusing. We want to give almost a full liter of fluid before we start the epidural induction. It helps prevent maternal hypotension, and that's the biggest risk, is maternal hypotension. And if we have maternal hypotension, of course, the baby then would have hypoxia. So we want to prevent that by giving more fluids. We have to have a CBC on the chart. We want to look at platelets. Ensure that the mom has normal, adequate platelets, and we're not going to be concerned about her bleeding into that spinal cavity, that epidural space. Anesthesia, of course, is called to the room. And then the fifth thing is that the patient has to be very cooperative. Now, if she moves during the procedure, or if she rises up and tries to sit up straighter during the procedure, anesthesia will stop and he'll walk out of the room because it's just too dangerous. So she has to be completely cooperative, which means you are going to have to be right next to her, in her face, holding on to her, whispering into her ear, whatever it takes to keep her relaxed and keep her in position during the multiple contractions she will have during the sterile setup, preparation, and infusion of the initial catheter. So a lot of emphasis, a lot of responsibility goes on the RN. Once the epidural infusion starts, we take vital signs every 5 minutes until the anesthesiologist deems that she's stable and there's not a risk of the hypotension. It happens quite frequently, and when she becomes hypotensive, the baby's heart rate drops very rapidly and stays decelerated until we resolve the problem. And so it is extremely dangerous. Now, the other thing about epidurals, when she goes back to laying down, we have to keep her relatively flat, which means that's a risk of supine hypotension to the baby. So we're going to have to tilt her hip a little bit, and we usually tilt the right hip over so that she's laying a little more to the left side, which improves the perfusion of the placenta. Left is always best. So hopefully you'll get an opportunity to help with epidurals. But when it goes wrong, when labor goes wrong, it goes wrong very badly. And one of the first things we would note is dystocia. Dystocia, when we break the word down, means difficult or not appropriate. So, labor dystocia is labor contractions are too far apart, they're inefficient, they're irregular, and so she's not having cervical change. There are some medical and chemical things we can do to augment labor. One thing is to get her up and have her walk a little bit. That might augment her labor. Changing her position. Talking to her and getting her to relax a little bit might also help these contractions get a little more efficient. Giving her a little fluid. Sometimes the fluid will decrease the contractions because the uterus relaxes a little bit, but then it will become more efficient. So giving her some fluids. breaking her bag of water, doing it what we call an amniotomy. Breaking the bag of water will augment labor. And doctors often augment labor by doing AROM, artificial rupture of membranes, to kind of get the laboring process started. When a patient is going to have an amniotomy, the nurse's role and responsibility is to know what the fetal heart rate is before and after the procedure. Very important to know the baseline. Then, of course, chemically augmenting labor, we go back to talking about Pitocin. We would hang Pitocin. Again, we put 20 units in the bag. Monroe has a different formula, so please pay very close attention to their in-house policy. They titrate Pitocin a little bit differently, and as long as it's in their protocol, you have to know what that is. So she'll have Pitocin to augment her labor or to make her labor stronger, more efficient, closer together. We can increase or titrate Pitocin up by 2 milliunits every 30 minutes until we get the goal of 2 to 3 contractions per minute. That's not the way I meant to say that. I meant to say contractions get closer together of approximately 2 to 3 minutes per contraction is what I meant to say. I apologize. I'm getting lost in my words. So chemically, we can titrate Pitocin every 2 milliunits per minute, every 30 minutes, until we can get contractions 2 to 3 minutes apart. That's our goal.